Bismillah ar-Rahman ar-Rahim. We are going to discuss a very important topic in cardiology, which is pulmonary hypertension. As we know, pulmonary hypertension means elevation of the blood pressure into the pulmonary, either arteries, veins, or capillary bed. By the end of this lecture, we should be able to define pulmonary hypertension, to mention the classification of pulmonary hypertension, to differentiate between different pathophysiologic and clinical picture aspects of pulmonary hypertension, and to properly diagnose a case of suspected pulmonary hypertension. We also should be able to differentiate different treatment options for pulmonary hypertension, either pharmacologic or procedural or surgical. We should be also able to differentiate different patients with pulmonary hypertension who have different prognosis depending on their functional capacity. So, by definition, pulmonary hypertension is a progressive increase in the blood pressure in the pulmonary vascular bed that eventually leads to right ventricular hypertrophy and or failure. Mean pulmonary artery pressure should be more than 25 millimeter mercury at rest, with pulmonary capillary wedge pressure less than 15 millimeter mercury. So if the pulmonary capillary wedge pressure is more than 15 millimeter mercury, this means that there is a pathology into the left side of the heart, either mitral stenosis, either aortic stenosis, or increased left ventricular resistance. By definition, the pulmonary hypertension means both mean pulmonary artery pressure of more than 25 millimeter mercury together with the pulmonary capillary wedge pressure is less than 15. So what's the pulmonary capillary wedge pressure? It means that when we advance a pressure catheter into the pulmonary artery and we advance it into pulmonary arterioles, then smaller arteriole, until it stops. So the catheter now is wedged, and we check the pressure, and if it is less than 15 together with the mean pressure of more than 25 millimeter mercury, this means that this patient has a pulmonary arterial hypertension. And the classification of pulmonary hypertension, actually we have a specific classification of pulmonary hypertension, meaning that we have 5 classes. The first one is pulmonary arterial hypertension, which is reclassified into 2 categories. The first one is idiopathic or primary. So primary or idiopathic pulmonary arterial hypertension, anything we call primary or idiopathic means that the cause is unknown. And the second subtype is secondary or systemic disorder. The second group is pulmonary hypertension due to left-sided heart disease, which is called pulmonary venous hypertension, where the pulmonary capillary wedge pressure is more than 15 millimeter mercury. The third type or third group is pulmonary hypertension that's associated with respiratory disease and or hypoxia, like COPD patients, chronic obstructive pulmonary disease, or interstitial lung disease, or obstructive sleep apnea, which is abbreviated as OSA. Obstructive sleep apnea is a disease that occurs into obese patients, short obese patients with short webbed neck. During sleep, the upper respiratory tract got obstructed, and the patient develops apneic episodes. So episodes of apnea with stopped breathing. So the oxygen saturation decreases while asleep, and the patient gets hypoxic during sleep as well. Those patients are exposed or prone to major complications like diabetes, like hypertension, like sudden cardiac death, like coronary artery disease, arrhythmias like atrial fibrillation. So it is very important to diagnose those group with obstructive sleep apnea. They also develop, as we mentioned, pulmonary arterial hypertension, and it is very important to treat such patients either medically with control of risk factors or even surgically with resection of soft tissue from the upper respiratory tracts or from the pharynx. The fourth group is the chronic thromboembolic pulmonary hypertension. It characterizes specific group of multifarious women, like women who got pregnant for maybe 5, 6 times, and every time she gets the female gets lower limb DVT with frequent showering into the pulmonary arteries, with the pulmonary vascular bed gets obstructed every pregnancy more, and eventually the female will develop pulmonary arterial hypertension secondary to this embolic or recurrent embolic episodes. The fifth group is pulmonary hypertension from unclear mechanisms, like due to connective tissue disorders, like due to hemolytic anemias, and that we will discuss later. Pulmonary hypertension due to unclear mechanisms. Pulmonary hypertension from unclear mechanisms or multifactorial pulmonary hypertension, such as chronic hemolytic anemias, sarcoidosis. Sarcoidosis is a connective tissue disorder, proliferative disorder, which is characterized by hypercalcemia and consolidative lesions. One of the characteristic pathologies is pulmonary arterial hypertension. One of the pulmonary hypertension etiologies due to unclear mechanisms is chronic renal failure with or without hemodialysis. A very important subset of pulmonary hypertension is pulmonary hypertension secondary to secondary to some drugs, like it is called iatrogenic pulmonary hypertension. So when the physician gives some medications to treat some disease, one of the side effects may be pulmonary hypertension. So we have four groups. It could be definite drug-induced pulmonary hypertension, as with the tricyclic antidepressants or toxic rapeseed oil, or it could be possible, like in cocaine, like in St. John's wort, or selective serotonin reuptake inhibitors, or pergolide. It could be likely, like in amphetamines, tryptophan or methamphetamines. Amphetamines, tryptophan, or methamphetamines are group of centrally acting diet or appetite suppressor drugs, where they are getting very famous nowadays because of the trend to decrease to lose weight. And one of the medications used are a group of medications called amphetamines. One of the side effects is pulmonary hypertension. Other medications with unlikely side effects to cause pulmonary hypertension are oral contraceptives, estrogens, and cigarette smoking. What about the pathophysiology of pulmonary hypertension? High pressure leads to vascular remodeling. Initially, the pulmonary hypertension changes, or pulmonary hypertension induced changes in the vascular bed of the pulmonary arteries are reversible, followed by some remodeling changes. Remodeling means dilatation, hypertrophy of the pulmonary arteries, with combined intima and media thickness increase, with perivascular inflammation. Pulmonary hypertension strains the right ventricle of the heart, causing it to be enlarged. So after enlargement of the right ventricle, it gets hypertrophied, and eventually it could fail. That results into right ventricular failure, which could lead to development of congestive heart failure with lower limb edema, abdominal distension, secondary to ascites, liver, dragging liver pain due to liver congestion. This figure shows the pathophysiology, or illustrates the pathophysiology of pulmonary hypertension. So initially we have normal blood vessel, and eventually we have the pulmonary hypertension vessel with hypertrophied intima and media, with both will encroach on the lumen with more increasing the pulmonary hypertension. These changes are irreversible at this stage. Eventually, the right ventricle will get hypertrophied, and eventually will fail, and will result in systemic venous congestion with lower limb edema followed by ascites and hepatomegaly or hepatosplenomegaly. The clinical picture. From clinical picture, we mean symptoms and signs. So the first important thing to remember about pulmonary hypertension, that symptoms and signs are usually not specific. This means that we have a pathology, or we have a disease which is difficult to diagnose. The non-specific symptoms could be dyspnea, which is especially dyspnea on exertion, and or at later stages it could be dyspnea at rest. Patients may be coming to you complaining of syncope, chest pain and chest tightness, leg edema and abdominal distension, secondary to symptoms of right-sided heart failure. As we know, abdominal distension would be secondary to ascites. Patients could be also coming complaining of dragging abdominal pain into the right hypochondrium, secondary to hepatomegaly, or dragging pain into the left side, secondary to splenomegaly. Signs. The signs could be hyperdynamic right ventricular impulse, secondary to right ventricular hypertrophy and enlargement. Signs of right-sided heart failure, being the lower limb edema, the ascites. The ascites could range from very mild ascites into tense ascites, and signs of low cardiac output, as hypotension, oliguria. As we know, oliguria could be a symptom or could be a sign, as if you have an admitted patient for whom you are monitoring his urine output, and the urine output is in the oliguric range, and here the oliguria would be a sign. Centrally or apically, we have loud pulmonary component of the second heart sound with narrow splitting of second heart sound. So this is very important sign in pulmonary hypertension, loud pulmonary component of the second heart sound with narrow splitting of the second heart sound. Tricuspid regurg and pulmonary regurg. Tricuspid regurg secondary and pulmonary regurg secondary to dilatation of the annulus of both tricuspid valve and the pulmonary valve, with resulting tricuspid regurg and pulmonary regurg. What about the investigations? We have chest X-ray investigations. Usually the chest X-ray in the early stages would be normal, but at later stages we can see some changes, like dilatation of the pulmonary arteries with central plethora or central marked dilation of the pulmonary arteries, while there is a characteristic pruning peripherally. Pruning means that the caliber of the pulmonary arteries of the vascular markings would be very small into the periphery of the lungs. So there is central plethora and peripheral oligemia. As you can see here in this chest X-ray for a patient with advanced pulmonary hypertension. Here is the centrally dilated pulmonary arteries with peripheral oligemia. As we can see, there is as well lower fields. There is interstitial pulmonary fibrosis. As we mentioned, chest X-ray may show dilation of main pulmonary arteries and peripheral lung oligemia, right side dilatation of the heart, or maybe even normal. In the last chest X-ray, we can see also that the heart is enlarged with right-sided dilation configuration. This means that the right atrium, right ventricles, both are dilated. And as we said, the chest X-ray may be even normal. ECG, what about the electrocardiography in cases of pulmonary hypertension? We have different findings that could be present. So the patients could have right heart strain in form of right ventricular hypertrophy and right atrial enlargement. There could be right axis deviation, and there could be also anterior chest lead changes like segment depression, anti-wave inversion. As we can see in the as we will see in the following ECG. So first of all, there is a right axis deviation as evidenced by a deep S wave in lead 1 and large R waves in lead 3. We can see also the P pulmonale. We can see the dominant R in V1. And we can see also the SDT wave changes in anterior chest leads from V1, V2, V3, V4, and V5. What about the echocardiography? Echocardiography is a very important, and it is the golden non-invasive diagnostic tool. And we can use echocardiography. Actually, you can use the Doppler ultrasound in echocardiography to estimate the pulmonary artery systolic pressure and to diagnose pulmonary hypertension. As we said, the cutoff point or the diagnostic pressure is a mean right ventricular is a mean pulmonary artery pressure of more than 25 millimeter mercury. And as we said, echocardiography is the golden standard technique non-invasively to diagnose pulmonary hypertension. So we use echocardiography to diagnose the systolic pressure of the pulmonary artery. We use it to diagnose the underlying etiology, like left-sided heart disease, like pulmonary, like mitral stenosis, congenital heart disease with intracardiac shunts, like valvular heart disease, and eventually like cardiomyopathy affecting the left ventricle. We use also the echocardiography to estimate the right atrial area, the right ventricular size and function, to assess if the right ventricle is only hypertrophied or hypertrophied and in failure. To assess also the degree of tricuspid regurg. Other investigations for pulmonary hypertension include pulmonary function tests to diagnose chronic obstructive pulmonary disease or idiopathic pulmonary fibrosis. Another test is also the polysomnogram. Polysomnogram is an overnight oximetry checking test. So the patient is admitted to hospital or for overnight sleep, and oxygen saturation gets monitored. And if the patient has obstructive sleep apnea, this means that his or her oxygen saturation drop at night with periods of apnea during which hypoxemia occur. So this means that, and if the apneic episodes are more than certain diagnostic limit, this means that the obstructive sleep apnea is diagnosed. Those group of patients, as we mentioned earlier, are high-risk patients. They are prone to arrhythmia, to coronary artery disease risk, to hypertension, diabetes risks as well. So it should be promptly and vigorously treated. And investigations also include ventilation perfusion scan. It's called VQ scan. I think we have studied that in pulmonary embolism. And this test looks for evidence of blood clots along the pathway to the lungs. So if a high probability VQ scan, this means that the patient has perfusion defects, which means that the subtype of pulmonary hypertension or the cause of pulmonary hypertension could be thromboembolic pulmonary hypertension. One of the tests as well is the pulmonary angiogram, which is the golden diagnostic tool, but it is invasive test. It looks for blood clot blockage in the pulmonary arteries, and it is used also to diagnose a subtype, which is the chronic thromboembolic pulmonary hypertension subtype. Right heart catheterization, as we said, it is the gold standard test, but it is invasive test. Looks for hemodynamic variables such as mean pulmonary artery pressure, such as the pulmonary vascular resistance, such as the mean right atrial pressure and the cardiac output, or what's called cardiac index. This is a representation of the right heart cath when we get access through the inferior or superior vena cava, then to the right atrium, then to the right ventricle, then through the pulmonary artery. We can check the pressures into the both sides of the pulmonary arteries, right and left, and we can advance the catheter until it is wedged into a small pulmonary arteriole, where we can check the pulmonary capillary wedge pressure. Um, from the investigations are the laboratory investigations. So lab investigations include liver function tests. They include a complete blood count for anemia, for reactive thrombocytosis. For the liver function test should test also for abnormal transaminase, like they will be increased in liver congestion, or if the liver itself is the cause, like in connective tissue disorders, and autoimmune screening such as anti-nuclear antibodies in the ESR, erythropoiesis sedimentation rates, and other tests for autoimmune markers. A screen for human immunodeficiency virus. HIV or human immunodeficiency virus causes pulmonary hypertension by inducing vasculitis, which precipitates pulmonary arterial hypertension. Actually, the HIV, if it causes pulmonary hypertension, it is type 1 pulmonary hypertension or group 1 pulmonary hypertension. Arterial blood gases to determine the level of oxygen in arterial blood, and to check if the patient is in need for oxygen. And one of the tests is B-type natriuretic peptides, which are high in pulmonary in right-sided heart failure secondary to pulmonary hypertension. The prognosis, it is very important to assess the prognosis of pulmonary hypertension, because it helps into risk stratification of the patient. So if the patient's prognosis is poor, so you may choose to palliate, or just choose simple measures to be used with the patient. Or if the patient's prognosis is good, so this means that you have to use strict measures with the patient to be vigorous in treatment. So the prognosis is different according to the WHO functional class of the patient, based on the impairment of the exercise capacity, assessed by 6 minutes walking distance test. So a 6 minutes walking test in a corridor, long corridor, we ask the patient to walk for 6 minutes as fast as he can, walking, and we assess the walking distance of the patient. According to this walking distance done by the patient in 6 minutes, the prognosis will be different. And the right ventricular functional assessment using echocardiography, cardiac magnetic resonance imaging, right heart catheterization, and biochemical marker testing. So low risk patients, the 6 minutes walking test will be more than 440 meters. Intermediate risk patients with estimated 1 year mortality of 5 to 10%, while the high risk group is they have an estimated 1 year mortality of more than 10%, and those patients have low functional capacity with 6 minutes walking distance of less than 160 165 meters. And finally, we come to the treatment options for pulmonary hypertension. First of all, we have general measures. Patients with pulmonary arterial hypertension, they should avoid pregnancy. They should get the influenza and pneumococcal vaccines every year, annually. They should have supervised exercise training and avoid excessive physical activity that leads to distressing symptoms. We should also supplement oxygen or give extra oxygen therapy for partial pressure for those with low partial pressure of oxygen. So if partial pressure of oxygen, which is abbreviated as PO2, if the partial pressure of oxygen or checked arterial blood gas oxygen less than 60 millimeter mercury, or the patient has WHO functional capacity between 3 and 4, meaning that the patients are distressed or dyspneic at less than ordinary effort or even at rest. And patients as well should avoid general anesthesia and use epidural instead if necessary. Supportive treatment: patients should be instructed to reduce the salt intake and to use diuretics as needed to relieve edema or congestive heart failure. They should be instructed to use oxygen as needed, flu with flu and pneumococcal vaccines. Patients should be also anticoagulated if severe pulmonary hypertension to avoid in situ pulmonary artery thrombosis, and anemia and iron deficiency anemias should be corrected. For group 1 medications options, these medications are peculiar or specific for group 1 patients only, while groups from 2 to 5 they have the main treatment option is to treat the cause. So for group 1 medications options, we can use vasodilator medications to treat pulmonary hypertension. The options are either calcium channel blockers as vasodilators, endothelin antagonists. We know that endothelin is a very potent vasoconstrictor, so endothelin antagonists are vasodilators. So endothelin antagonists can be used to treat pulmonary arterial hypertension or group 1 pulmonary arterial hypertension. We can use also the phosphodiesterase 5 inhibitors like sildenafil or tadalafil, which are the like Viagra. As we know, they are used for male impotence, but it was found that they decrease the pulmonary artery pressure as well, so can be used as vasodilators in pulmonary arterial hypertension. Finally, we can use the prostanoids, which are prostacyclin analogs, and they are very potent vasodilators and can be used in different forms like inhaled, subcutaneous forms, or even IV pumps to treat pulmonary arterial hypertension. First of all patients should be referred for pulmonary hypertension tertiary center to guide treatment and ongoing management of pulmonary hypertension. Group 1 secondary pulmonary arterial hypertension like collagen, scleroderma, systemic lupus, liver disease, congenital heart disease, drugs, toxins, HIV infection could be tried. The vasodilator therapy could be tried as well. Other groups, they are managed differently, and vasodilator therapy is not recommended. Before starting vasodilator therapy, patients should be tested for vasoreactivity, and it's called a vasodilator challenge test with more than 20% acute drop in mean pulmonary artery pressure and pulmonary vascular resistance. If the patient has more than 20% drop, we should begin with calcium channel blocker and we should titrate. And if the patient maximum tolerated calcium channel blocker dose is not achieving the needed drop in pulmonary artery pressure, we should shift to another class like endothelin antagonists, like phosphodiesterase 5 inhibitors, or like prostanoids. Other things that could be considered as well, like chronic pulmonary emboli removal, which is called pulmonary thrombectomy surgically, or some surgical procedures like atrial septostomy or transplantation. And transplantation could be either heart with two lungs, it's called heart double lung transplantation, or double lung transplantation if there is no right-sided heart failure. We could also use a palliative procedure like atrial septostomy, where we dilate the intra-atrial septum, producing a puncture with a resultant right to left shunt as a palliative measure to increase cardiac output. In summary, pulmonary hypertension is diagnosis of a disease with many underlying subtypes. Echocardiography is the mainstay of non-invasive diagnosis, while the right heart catheterization is the gold standard diagnostic tool. Drug-induced pulmonary hypertension is common as well. Before starting vasodilator therapy for group 1, vasoreactivity testing should be positive, and groups 2 to 5 have different therapy, and the main therapy for them is to treat the cause. Always treat cause of pulmonary hypertension, and the prognosis is variable and depends on functional capacity of the patient.